There we go. Hmm. All right, folks. Hey, we just have a couple of minutes. There's Josie.
Hi, can you hear me?
I can hear you.
Perfect. Okay, perfect. Good to know.
Look at that.
Wonderful. All right. 11:59, we'll give it a couple more minutes.
Yeah, why not? And let's see. So if all goes well, people should see 2 comments in the chat. Do.
Yes, I see your comments.
Perfect.
All right, welcome the folks who are here and welcome to the folks who are just signing on. We're just going to wait one more minute and then we'll get started. Are you ready, Chris?
Always.
All right, perfect.
They may not be, but I am.
All right, perfect. So welcome everybody. Thank you for joining us today for our second webinar in our series. I'm going to introduce Dr. Chris Prue. He's our Director of Education at Digital. He's also in private practice and he consults as a physical medicine and rehabilitation specialist and a performance coordinator for individuals and athletic teams. He has done many guest lectures and he holds a Doctor of Chiropractic in Exercise Science, a Master's of Science in Exercise Science, and a Bachelor's of Science in Sport Management and Health Fitness. He has over 25 years of experience in sport and clinical sciences. And he has authored and co-authored several peer-reviewed publications and has worked across the US and the world, actually. So without further ado, Dr. Chris Prue.
Wow. Thank you, Josie. You make me sound good on paper anyway. Here's a funny thing. I was giving a webinar one time and we were going for probably 15 or 20 minutes. People kept pinging me and sending me messages and telling me that no one could hear me. So that goes to show how comfortable I am in my own skin. I can talk to myself for 20 minutes. All right. So we're not going to do that now, but hey, thank you all for joining us. We've got people from all around the world, in fact, which is pretty cool. So I try to keep my jokes neutral so they're easily understandable, but I can't make too many promises. So without further ado, let's get into this. I'm going to share my screen here and you'll see a little bit of matrix going on here in a moment. Pew, pew, pew. All right. So if all goes well, you should be able to see my presentation. Again, thank you, Josie, and again, thanks for everyone who is participating here. So this is actually part of a series that we're calling "Everything is Better with Data." which is kind of fun and right up my alley because I like data and information. And really, anyone that performs evidence based practice, which is probably the most all of you, we use it to inform our clinical decision making process. We use it to inform our clinic process. We use it to inform and create patient compliance. And so it has multiple layers to why we would do that. And so, just to remember that evidence-based practice includes a third of that paradigm in terms of what the patient perception is of what's being done to them. So it is important that we educate them and they know exactly what the problem is and what we're going to be doing about it. And today more than ever, being able to provide the amount of information. What's cool is the visual aspect and putting people in their situation. So this part is called Health from the Ground Up, Behold the Foot. Now, it's always a challenge for me to not say too much. As anybody that knows me, there's usually a bet going on whether or not I finish on time. But so we're going to have a little bit of emphasis here, and really kind of two components and then a subcategory to one of those components. But the first one is utilizing data and not to be afraid of data. And I think, to quote one of my colleagues at when I was at university in a committee, and he was the statistics professor, and he said, don't collect data just for the purposes of collect data unless you're going to be doing something with it. Otherwise, it just becomes, confusing and useless. And but don't be afraid to collect it. And really, it's the implementation process, I think, where we lack a little bit. And that's why it's important, when we continue our education as clinicians, to make sure that we stay on top of, innovations. And that sounds sometimes strange for those of us in the physical medicine space. I know some of you are also surgeons, and so keeping up to date on surgical procedures, various types of physical agents, how we even treat patients, even the healthcare perspectives and policies that are put before us to sometimes dictate the way that we actually treat patients. And then another one is dynamic assessments for functional outcomes. I'm going to be using sort of breaking it down into two examples, obviously for the sake of time, because we don't have all day, and we could talk about the foot and pain and clinical conditions for a really, really long period of time. So that's why we kind of put together this series perspective, and we're going to continue this conversation. And I like this quote by Jordan Peterson. The best way to learn about something is to actually talk about it. And so as I do these, I come up with different ideas, or as my students used to say, "Oh my gosh, you just had an epiphany, didn't you?" Because I get this strange look in my eye and like, that's a way to kind of look at something. So the reason for this one was to talk about from the ground up, because the essence of this series is talking about locomotion and dynamic movement assessment, which is a fancy way of saying, putting people into their characteristic, activities of daily living, or things that people are really normal and are supposed to be able to accomplish, on a day-to-day basis. And then there's some characteristics associated with that as well. So the idea is to kind of look at this locomotion perspective from the foot. And I call it pain, but I want to present to you an idea or a thought process that's actually really not about pain, because I will get on my soapbox. And if you've heard me present before, sometimes I tell you my claim to fame, or what I want to be known for, is being able to save people from having, surgical procedures that don't otherwise shouldn't have been required, because we could have stopped them, either through a predictive nature or through a more conservative approach as necessary. And so that's kind of where this data aspect comes in, and as a result of the technology. So a little bit of an introduction. I'm not going to talk a lot about locomotion or gait, again, just for the sake of time. I'm going to make a little bit of an assumption that you're familiar with the basics, And also, the essence of this talk and a lot of these is not really getting into deep biomechanical components with regards to locomotion. We're saving that for another time. So we do have some courses coming up that are going to get a little bit more into the weeds, as we say, a little bit deeper dive into that kind of stuff. But really, the essence of this is looking at, how can we use dynamic movement assessment from a multiple perspective in terms of implementation into clinical practice. And it's across the spectrum. It could be from performance, it could be if you're dealing in sports medicine or the general population, the older adult population, the younger population. How are we able to better capture some of this information and either make it easier for us to make clinical decisions or improve patient retention, improve outcomes is always a potential goal. So I'll discuss two real foot issues that I think are pretty common. Well, I don't think, I know it's in the literature that way, and sort of how we're utilizing data. And I'll give you some of my examples too as we talk about that, and then sort of bring it home in terms of where we're at, and at least hopefully give you some things to think about when you leave here today or watch this at a later date. So human movement analysis, it's really at the essence of what it is that we're trying to accomplish. Overall movement analysis is, as we refer to, sort of these performance-based outcome measures. There's another way to look at that in the clinical literature, in the clinical data, we also talk about performance-based outcome measures from that clinical perspective. That's certainly one side of it and me. And then there's, like Josie said, there's the sports scientist and performance aspect of what I do. And that performance-based outcome measures is sort of a whole body experience. And so, for example, is, how fast somebody can run. In our case, at that clinical level, is how they actually walk, and we can break down the movement analyses into the various components, which some of these require equipment and data. So historically, that's been very challenging, and in the university setting, in the research setting, at my disposal, I had a lab that I ran and had a lot of technologically advanced equipment throughout the spectrum of my career in education and even in practice and in teaching, having access to that type of equipment. But we don't all have that. And that's why there's been development of field tests, for example, to be able to bring qualified examples to provide quantitative information in making that clinical decision-making process without the expense or even the portability of some of the things that we do, or time, right? So if you work with large groups of people, if you're the sports physiotherapist or an athletic trainer, we used to open the door to the clinic. Wow, there's two of us working and 50 athletes come in and we need to get ready for practices and potentially games and things like that. So time orientation and that was a big perspective. So there's multiple factors into what brings in the technology or not bring in the technology. So I like to use the term locomotion. And the reason for that is when people think of the term gait, it's old or antiquated in the thought process. Because when we say gait, people tend to be hyper focused on all of that fancy equipment that, used to be necessary to provide all of that data, or the earliest implementation of that type of analysis, gait analysis into the clinical setting was very, very clinically oriented. And one of the earliest introductions of gait analysis into our clinical world was actually, in pediatrics and cerebral palsy. So that brings up a certain thought process, and sometimes people will just kind of shut themselves down versus talking about it in terms of locomotion and moving your body from one point to another, right? And so what's involved in that process? And yes, probably the most basic one is going to be walking. And that's why we're going to talk about that, because it's a very powerful tool with regards to evaluating the multiple systems aspect of that human being. So yes, we could refer to it as gait, but locomotion walking, it sounds better, right? And that it opens up people's minds to, well, okay, well, what are you talking about? And if you've heard me speak in the past, I did a lot with physical agents, therapeutic modalities, and traction, for example, mechanical traction. Old term. I used to use the term spinal distraction because it opened up people's minds to say, okay, well, what's changed in 4,000 years? Well, we can look at the evolution of walking here and we can say, well, what's changed? Well, really the technology. The process hasn't changed, which is a good thing. So walking as a component of locomotion, it's a timed execution, right? So there's multiple processes that are going on, which includes your biomechanics, the physics, obviously anatomical features, the neurological components, right? Reflexive as well as voluntary and involuntary patterns that bring in a high component of the neurological system. And then, well, to be able to have that metabolic activity, the energy to be consumed by the musculature, to be involved in that locomotion process through muscle contraction, mobility, is going to require things that address the metabolic systems, right? So that's going to be the respiratory system and the cardiovascular system. So locomotion or walking has quite a breadth to it in terms of the amount of systems that are brought into that. Now imagine this: if we can sort of break those systems down and use this as an overall evaluation, imagine being able to sort of, like we see in some of these movies in the future, whoop, just do a scan of the entire body and all of a sudden it spits out all this information with regards to all the different systems in the human body. We can kind of get a little bit of that with walking, right? But we're gonna focus that down and look at the foot. Now, what I want to lay out is sort of the differences between static evaluation and dynamic evaluation. I want to take dynamic evaluation and make it a step further, which is going to be beyond observational, but actually using some of this data. So one of the reasons we developed, over the years for the static evaluation was due to lack of having that amount of equipment available to us in terms of innovation to collect beyond just observational data into the more technologically advanced, which was usually only for the people that had these laboratories with all of the fancy and very expensive equipment. We're not taking away from that. I mean, that was a powerful aspect in being able to um, deliver and configure even these more static analyses. But what I want to lay out here is that they're different, and that if we think about, and I'll bring this question up in a few moments, is ask patients, are you in pain while you're stationary or mobile or both? Right. And so a lot of times, if they're in pain while they're stationary, there's probably some degradation to some tissue. There's usually an inflammatory response. But if they're not, but then they become painful during dynamic aspects, it's a different animal, right? And that means that there's probably going to be some level of different evaluative effects to it. Like even when we just evaluate posture, we know that there is an ideal posture and that non-ideal posture is actually, they're more metabolically efficient, right? They don't consume as much energy because we're putting the stress on a lot of the connective tissues versus the musculature to hold someone in an upright posture position that's more appropriate to maintain the static posture position of the musculoskeletal system and the connective tissue system. So that's a great static, and but how do we translate that into mobility? And we see this sort of across the spectrum. So this is just looking at Treffler and et al.'s work with children, and what they did was they wanted to separate the flat foot versus sort of the normal foot. But a little bit different is that it's a flexible flat foot. And what we mean by that is it's not rigidly held in place. And what we've identified both in the adolescence and through adulthood is that flexible flat foot has a little bit different capability to it. And I'm going to show you another paper here in a moment, with regards to what that implication is. But essentially looking at, the flat foot in the flexible orientation, and the fact that from the static position, it presents very similar to like someone who's overpronated or has navicular drop compared to someone who doesn't. And you would think that that would be problematic during dynamics, but in fact, it resulted in not being problematic. And because it was referred to as a flexible flat foot, that sort of, gives some, and we already know this, but gives us some implications as to the intrinsic value of how we can correct some of those things, right? And think about this from the perspective of, someone who's extremely flexible, one might even say over flexible, and say, are they able to control that? And the answer is, very typically yes, if they have the appropriate motor control strategies, strength, and things like that. So this one is actually done in adults, but they use runners. And I like showing this one because we're pushing ourselves to sort of that higher level. And as we go from walking to running, there's going to be a higher impact load. And the reason is because we've gone from having this double support phase into this flight phase, which is a big difference between walking versus running. So we actually have to land and then take off again. So much higher ground reaction forces. And so what we find is that during the dynamic aspect, that as we start to increase some of that load, there's greater deformation and a result of not only ground reaction forces being higher, but also if we were to look at the time constraint, right? Because if you are in fact that runner or an athlete, then you know that to run faster, you're going to have higher peak forces pushing against that ground, but over shorter durations, or a combination of one of those two things. And so what we've been able to show is that, having that difference between these two groups, that, the static alignment was not the best indicator that they were actually going to have a change or an increase in mobility during an activity type pattern with walking or running, especially when it comes to something like running. So the longitudinal arch is another big one. And I'll talk about, sort of some of these predictors from that static standpoint. And I'm not eliminating, that we use static analyses. I think it's still very important, but to show that it doesn't paint the entire picture. And sometimes some of these things are so detailed is that you can't just pick them up with observational methods. So I'm presenting this one because there's actually a condition here. So medial tibial stress syndrome, which often can result in that overpronation, or what's referred to as that flat foot. And so typically, in that static position, or as referred to in the study as quiet standing time, that actually didn't even translate into when they were performing the gait analysis. And so another good indication that, what could have happened was someone maybe posted or did an insert or did something, to those individuals, when in fact during dynamic analysis it wasn't necessary, right? So it wasn't something that needed to happen. Static and dynamic foot posture. So this is a meta-analysis. I like to show these last because, in a meta-analysis, you have to be careful. The reason I like it is because they're very rigid on their acceptance into the paper. So they tend to be very, very small. And so they're, in a meta-analysis, obviously the attempt is to, reduce any sort of bias, which is interesting because I obviously have a bias, right? Because my focus is to help lay the groundwork, or at least the thought process, to say that, we should probably consider some dynamic evaluation in addition to, and maybe even replace some of the statics in general. But so there has been historically some relationship to static measures, especially during things like mid stance, right? During what's referred to as foot flat position, right? Because we come into a heel strike position, slightly inverted calcaneus. We are slightly supinated at the midfoot, and then we are reducing supination and reducing heel inversion and going into a more neutral position, which some people may overpronate during that maximal loading time and phase in that foot flat position. So there's a little bit of evidence that says there's some association between that subtalar position and leg stiffness, but it's not that solid, and there's not a lot of other evidence in some of these others when we're looking at that static position and trying to, as we say, make that leap of faith or project that it is going to impart the dynamic aspect. And again, you know what? If your patient is constantly standing and they don't really move a lot, then absolutely, we need to take that into consideration. And in fact, maybe a static posture position might be more relevant to what it is that we're doing with our patients. I like to show this paper because this is a really good example of, it's sort of that flexible flat foot, right, with these patients. Flexibility meaning that, we can put them into a position where otherwise they have a normal sort of navicular height or medial longitudinal arch position, and adding a neuromuscular stimulation to that. So in these particular patients, we can actually add that stimulation and we can get a normal foot position. So in other words, should we do anything sort of, as a blocking feature or an insert, when in fact it might have more to do with a rehabilitation process? And again, we wouldn't have known or had some difficulties determining, those relationships if we didn't do sort of that dynamic analysis. So in summary, like I said, I never take away statics completely because a lot of people spend a lot of time in that static position. So the reason for the addition could have something to do with the fact that, well, how do they work when they're working dynamically? And maybe that's potentially a better opportunity to figure out exactly what the problem is. And there is, some really good relationship to the fact that, when someone has an overpronation during dynamics, right, you may or may not pick that up in a static position, right? Especially if it's an intrinsic issue, and being able to absorb that load. And I'm not even talking about overloading like running or jumping. This is really even just walking. So the running and jumping aspect is certainly another consideration. And I know some people are thinking, well, why would I have them jump? Well, if you're working with an athletic population, that's a very popular method to analyze, the lower extremity performance, from that baseline and benchmark testing, but also with regards to return to activity and whether or not we're on the right path or we completed an appropriate rehabilitation program. The flexible foot, is a really good example of showing that the statics is not the best way to determine whether or not, that's going to be the same when they're in that dynamic situation, and that it may change the way that we could approach the rehabilitation aspect with regards to what the intervention may look like. And especially if we don't want to be putting in any sort of support in there that may not belong, or all of this sort of at the end of the day is if we can use dynamic evaluation to potentially predict, right? So let's say it's not about pain, and it's really just about performance or the prediction of a potential future pathology. That's actually my really big play here is, to show first off that, the dynamic aspect is kind of an important thing. Now, I've worked with a lot of folks in this sort of scenario in that, it's a barrier to implementation into clinical practice when it comes to, well, geez, is this going to take me an extra 30 minutes, per patient? And in the lab, And so, many years ago, yeah, I mean, that's what it takes. And to do even today a very thorough evaluation, of everything that could be necessary, it's going to take a long time, but those are the special cases. So, is there an opportunity that we can capture a lot of that useful data within the clinic within a relatively short period of time that may actually take away from some of the other things that we were doing? So, that's going to be time effective. Maybe it might even speed up the process. Or what if we think about this? Maybe it's going to pick up on something that I couldn't tell before, right? Before I started doing this, giving all of the different aspects with regards to locomotion, right? All the different systems and how they interplay. And that kind of leads us to, well, how is this possible, Chris? Right? Well, this is advancement in technology, right? And it's a really cool time because we're seeing some interesting opportunities here. So artificial intelligence in general, it's coming whether you like it or not, and we're seeing it rampant throughout healthcare, and for a few reasons. One is the potential efficiency of it. If it can reduce the time necessary by an individual, and that either allows me to see more patients with better opportunity to converse with them. It may also improve the diagnostic aspect. So, for example, the implementation of artificial intelligence in imaging studies, mammographies for detecting breast cancer within 1 year, improved by 11%. So that's a pretty good reason to actually do something, is it improved the outcome. The best part is it doesn't really add to a lot of time. And in fact, it's taken what we used to do in a lab, but might have been a little bit more difficult. And that's the essence of artificial intelligence, is thinks like a human, but it sort of removes all of the aspects of a human that can potentially get in our way. The best part is it aggregates data much easier and allows us to use other computational methods. Um, if you're familiar with the clinical prediction rules, right? So in early 2000s or so, and a lot of that was developed because of our computational methods in statistics. And so prior to that, it was very challenging to be able to segregate out the different components of a treatment approach to say what was what. And that's why historically a lot of research studies were done on just one thing, just laser, just traction, just one exercise, and to be able to control all those variables. So it's actually mathematics that's allowing us to do that. But a step further with artificial intelligence is now we can implement also what's referred to as deep machine learning or machine learning processes to feed algorithms to potentially do a better job. So it's coming, and that's one of the reasons is it does a great job at assisting us in developing these processes. So why use locomotion, even though we're kind of focusing on the foot? Well, because of all the different systems that it integrates with regards to locomotion or walking, that it gives us an opportunity to almost be like a futuristic movie in where we're doing one scan and we're able to evaluate, potential reasons that someone may not be functioning appropriately, not only from a pathological standpoint, but as again I joked earlier that my goal in life is to reduce the number of joint replacements that could have been stopped or prevented through some means, right? Either behavior modification or earlier detection, before it happens too long. Because globally, we are typically a management by crisis system when it comes to healthcare. Not every country, not every healthcare system, but that's what's very common. And so what's interesting with using a locomotion is it's fantastic at, again, evaluating all these different systems. There's a lot of research behind the various aspects, the metrics and the biomarkers. And as we continue to utilize technology and develop these biomarkers, we'll get even better and faster at evaluating these things. So looking at, I typically always, when I talk about locomotion analysis, I remove the foot, because I think the foot stuff is obvious, and really any obvious condition. But from congenital anomalies, post-surgical procedures, I always I get the question, would this be good to evaluate someone after they've had knee surgery or ankle surgery? And the answer is Yeah, but the argument from other people are, well, I don't need fancy equipment to know that someone's not walking right when they just got out of surgery, right? But where we look at it is sort of that pre, the post, and maybe the later stages, when it comes to the resolution of our intervention to make sure that whatever it is that we've done was actually successful, right? And what we're finding too is some of these biomarkers may give us a greater opportunity to prevent something sooner than later. And that's, kind of what I'm getting at today. So the two examples are going to be plantar fasciitis and neuropathy. And like the first one, plantar fasciitis, I would say, again, it's pretty simple. If someone has foot pain, they're going to walk funny, right? And so, but what if we could do it pre-injury and we could halt someone from having that problem? So plantar fasciitis is an interesting condition that we'll talk about, but that's why I'm referring to this as sort of a pre-pain conception, right? Or a call to action, right? So if we could better evaluate people, right? Because what is pain? And pain is sort of that symptomatology that, wow, we've gone way beyond just dysfunctional movement. Now, the tires are about to fall off the automobile, so it's time to get new tires. So I present this paper because a lot of people think when we look at our healthcare systems, it's sort of relative to maybe lower socioeconomic or lower financial status, and that it's really not the case. And in fact, your level of education doesn't protect you from having foot pain. Here's the interesting thing too, that so many people that have foot pain also have many other conditions, and that one of the reasons they may actually come into the clinic is because their foot pain is so bad, and then we find out that something else is going on. So this whole call to action, and I always ask this in live face-to-face presentations, because I could see people, is I ask people, what's the ultimate goal in conservative physical medicine and rehabilitation? Most people will say it's to get people to move better, right? And that in and of itself indicates that it's about movement, because movement is what we use as one of the metrics with regards to thriving in life. And so the problem that when we use pain as that metric, it's not too late, but it's much later than, again, it's like waiting until your brakes fail and you crash with your automobile before you actually change them. We don't have to wait that long. And so in both research and even in the way that many people market their healthcare facilities is, we treat neck pain, back pain, whatever the case may be. And unfortunately, that's become this prognostic indicator when it shouldn't be. And we've used that in research too, to show that, oh, people can have derangement of any tissue, the knee, the spine, the foot, whatever, not be in pain and work okay. And basically indicating that, there's no symptomatology, so therefore they're fine. But they're using pain as that metric when again, pain is not a performance outcome measure, right? It's a symptom. Instead of saying, well, what if we use sort of a dynamic measure? So instead of just saying that, yes, people are walking around with all of these problems, but and they're not in pain. Here's the irony: is most conditions that have derangement to the tissue, when patients present in pain, there is a correlation. Why do you suppose that is? It's because by that moment in time, there is that relationship. And so pain or the absence of pain is not really a good indicator of one thing or the other in terms of resolution, or the fact that nothing's wrong. When it is present, that's the one thing it does tell us, is that there's definitely something wrong. So the absence of pain doesn't necessarily indicate health. Those of you that work in sport, like, this is a much easier concept, because you're thinking, why is my 100-meter sprinter, his 100-meter time is increased by 5/100ths? Well, then we start to evaluate and try and figure out what's going on. But in the general population, we tend to wait, and that's a problem, especially if it's related to, and I use the example here of like diabetes mellitus, that neuropathy has such a bad situation from increasing the problem not only in the foot, which will be the focus, but blindness and heart disease and things like that. And that if we could catch these movement disturbances earlier, and again, it's tedious. We can't just go in and check every single thing. So if we had an opportunity to measure, something that was a multi-system capability to it, that would be really cool. And there's many studies that show that earlier intervention actually results in not only less invasive procedures, but it saves money. Right. And I always tell my patients, I'd much rather treat you because you got injured, hiking or biking or doing something physically active than for a chronic, condition. And we spend a lot of money globally. And in fact, the top consumers of healthcare dollars are actually, chronic pain globally. So plantar fasciitis. So plantar fasciitis is one of the examples here. So the reason that we chose this is it's one of the most common reasons that a patient will enter your clinic for foot pain, right? And basically 1 out of 10 people is going to experience plantar fasciitis pain and potentially get treatment for it. But as high as 80% of adults, or in general, people experience foot pain at some point in time in their life, which is very similar to like low back pain, for example, which is high on my list of things to talk about. So it is more common in certain presentations, like being middle-aged, obese, um, so the higher BMI. What does it look like? Well, even before we start to experience, that classification, and once we do experience that classification, we do see sort of this thickening and the fibrosing in, the plantar fascia. And oftentimes we'll see a calcaneal periostitis, right, which is the initiation of that heel spur, which is when people get the heel spur, they're actually at higher risk of plantar fasciitis, and which one came first. So what that tells us is that even we call it plantar fasciitis is more of an inflammatory stage. And by the time people actually tend to come see us, that's what it is, but it's actually a degenerative condition, right? And so we may be able to pick this up sooner than later and before someone gets to such extreme pain and be able to actually do something about that. So from some of these statics, previous history and increased loading during running makes you more predisposed. So previous history in general, it kind of makes sense. In some studies, 70% to 80% of the people that had plantar fasciitis that were non-athletes had a higher BMI, right? They were overweight. Higher percentage of females. I just read a study in 2021 that shows that, the greater number of children that were given birth to also increases the risk. Now, that's also related to some other potential problems, but we do in that multi-parity situation see an increase in BMI. We also see an increase even in the static pronation as well as the dynamic. Decreased ankle dorsiflexion, and not only during statics but also during walking, so we can actually pick up the angulation in the sagittal plane during a walking analysis, for example. Decreased dorsiflexion of the first metatarsal phalangeal joint, lower longitudinal, medial longitudinal arch, drop in the navicular height. People that present with really high strain activities. So in general, an athlete may be more predisposed, especially if they have a strike pattern that is indicative of that potential higher strain. And flat feet. So flat feet in the active as well as the non-active. But again, that's where we want to be able to, kind of tease that out. So that when you get a patient in that has an active plantar fasciitis, that they're in pain, I don't want to say it's easy, but it's easy because they don't walk right. So it makes it a little bit easier. I present this. We were at a conference and I was talking to an engineer who works in another another program and develops biomechanical assessment tools. And so he had plantar fasciitis on one foot, and it changed his gait pattern so bad. Before he got treatment, he ended up with plantar fasciitis on the other foot. And so he asked me, if there's anything that we could do, or if we could just test him. So if you look on the right, here's pre-treatment and the left post-treatment. And by treatment, I treated him at the event, and we used shockwave therapy. And I'll talk a little bit more about that in a second. And so one of the things that we tend to see in people that are in pain is we see an increase in variability, especially if it's more acute. They just don't know which position is going to have the highest antalgic position. And if they have mitigated that, they tend to see some abnormalities. And so this particular person, it's on his left foot. So he tended to walk a little bit on the outside of the foot, but also with a foot progression angle that was almost internal versus his other side. And so this is pre and post treatment. So what happened was we did a walking analysis, and we walked for a good period of time. And then I treated him with shockwave, which, much to his surprise, I wasn't gentle. So I was very aggressive, and for certain reasons. But so he sort of had that opposite effect, that he's thinking in his mind, oh my goodness, this can't be good for me. How is this possibly going to make me feel better? So we did a follow-up even without him knowing, because the sensors that I use are embedded in his insoles. And as we continue to walk, we continued that evaluation, unknowing to him, and even in his gait line seemed to be better on the foot that we just treated. And again, that's not hard. When you remove pain of a condition, people tend to perform better, right? And that's why in the clinic setting, treat someone and they're going to be able to perform a higher volume load during their therapeutic intervention. So you can see his walking pattern. So this is during the stance phase. If you look over here on the pre side, you can see that again, he doesn't like to toe over and use that big toe on that first or second ray. So he stays on the lateral aspect of his foot. And we can see post treatment, he begins to normalize that, right? We do see a relatively high standard deviation within that, but that's normal. When you change a pattern acutely, you do tend to see a high variability in that, just like having pain. But so that was impressive to him to see. And then, like I said, his foot progression angle, just because not wanting to walk on the medial aspect, he tends to have a neutral and sometimes internal. So this is the mean, right? And then we saw, dramatic improvement over here on the other side. So typical things that we tend to see in both certainly when people have the foot pain, but even prior to that, we tend to see some abnormalities. And so if it's not at an extremely overt conscious level, they start to develop some nociception, which changes motor patterns. So we tend to see a decrease in the symmetry, often a decrease in the cadence or speed of whatever it is that they would normally walk at. We also tend to see a change in the gait line. Now, key factors also in plantar flexion and dorsiflexion. Both of those may actually be affected. So during the toe off position, as they're going from late stance phase into early swing phase, is common to see changes in the plantar flexion, as well as the characteristic, force production or acceleration into that swing phase in propulsion. So you may see a propulsion ratio off as well. And then we tend to see a lower dorsiflexion, because they're also often taking shorter steps and strides. So another one is diabetes, and I think this one is extremely important. I don't think there's life or death in plantar fasciitis, but it influences quality of life and can have some other influences. Having foot pain in general changes your gait pattern, and so then you can result in some knee issues and some hip and spine issues. But with diabetes, it's multifactorial. So imagine being able to use gait to monitor someone's diabetes, right? How they're managing it, making sure that they're doing what they're supposed to be doing. Because we could see the implementation or the integration of diabetes into the pathophysiological processes from multiple areas. But if we focus on cost alone, it's extremely expensive. We tend to see diabetes, especially in the foot, we tend to see it managed as a management by crisis again, right? And so we have a lot of people that are like, oh, we could do a better job at treating wounds. Well, how about this? What if we could do a better job at reducing the wounds to begin with instead of just treating them? But that actually goes even a further step back, is the neuropathy, right? Because the neuropathy occurs, then you have the wounds, and then wounds lead to lower extremity amputations, right? So that they have the highest percentage of lower extremity amputations of any other population. And it's because of the wounds, which is because of the diabetic neuropathy and the issues that diabetes has on all of these tissues. So if we could somehow predict before maybe someone even gets the diabetic neuropathy, and to know whether or not there's something that we can do. And as you can imagine, I'm here to present to you that there is, we can, in fact, even before they have diagnosed neuropathy, and that's why I put in parentheses here, or without, is we don't want to wait that long. If they have known diabetes, we should be monitoring them before they succumb to the diabetic neuropathy. So here's a really cool study, and these were comparing patients with neuropathy and those without neuropathy, and the control patients, and using sort of a real life scenario in 3 different surfaces: walking on the blacktop, walking on grass, and walking over gravel or stone. And there's a statistical difference between the diabetic patients and the control patients. In the diabetic neuropathy patients, we actually see very similar changes in their walking patterns even before they succumb to the neuropathy. So it's a really good and early indicator that says, we should probably intervene and do something about that, because they're on that path. But here's what I like about this too, is being able to show patients. One of my first patients when I opened my clinic, high blood glucose levels, heavy drinker, heavy smoker, in his early 40s, overweight. It was very challenging to make him compliant because nothing was affecting him yet. Nothing that I could show him, because even when he thought, high blood sugar, that's what everyone calls it, high blood sugar. What exactly does that mean? And as a result of being frustrated with his non-compliance, and he was much bigger than me too, but I took a chance and I laid it out. Here's what happens when you don't control your situation. So being able to provide, material for patient compliance, and everybody wants to walk. Everybody needs to walk, because that's your independence, right? Not being able to walk at certain speeds is a prediction of mortality and morbidity, right? And that's something that people can really understand. So here's another study, again, pre-diagnosed neuropathy with diabetic patients. And so matched for control. And again, a lot of similar spatiotemporal characteristics of the walking pattern that are going to be influenced by that, right? And some will argue and say, well, that it makes sense. I mean, if they're just not taking care of themselves, they're not eating right, they're overweight, they're not physically active, and those sorts of things. But when you matched for those characteristics, it probably was a mentality thing. But again, worst case is to predict it sooner, to let people know sooner, and to actually potentially make some of these changes. So the neuropathy that we can actually pick up, and pre-diabetic or just pre-neuropathy in general of these neurodegenerative conditions, we tend to see, one of the easiest things to see is actually high degrees of variability in a lot of these metrics, because they've lost their sort of motor control mechanism to establish normal patterns, right? We tend to see potentially affecting either bilateral or one side, versus the other, and we see changes in symmetry. Definitely see changes in speed and potentially stride length, not symmetrical stride length, but symmetry in the contact time. But if it is bilateral, what we'll be able to pick up is a shortening of their stride length relative to their speed, as well as their overall speed. Okay. The other thing that we tend to see is we start to see a dropping dynamically of that foot posture position in the contact phase, right? So we start to see that trajectory, like right here on this right side in the upper right hand corner graph. We start to see that trajectory pattern, happen as a result of that. What's interesting, even from the sports perspective, is these are the kind of things that we'll be able to pick up more readily because we're testing them. They're a runner, they're a jumper, whatever the case may be, and we'll be able to find out what exactly might be going on as a result of that. Well, as I present this as a thought process, or in adoption or adaption into clinical practice, I know there are barriers, in that not everyone is a locomotion biomechanist. Although I'd argue any clinician, we certainly learned enough to know what is necessary, and that with manufacturers and technology have done a great job at providing us the information and doing a better job because of things like artificial intelligence at giving us the opportunity. So like I said, there's some potential direct and indirect with regards to where it can fit. Even if it did exactly what all of my static measures did, but if I could have someone walk and not only do, all of those tests that have the same predictive capability to them in a shorter period of time, be able to have an assistant do that, but also as an overall health evaluation screening, and kind of give me a sense of how all the other systems are working together. That's a pretty cool thing. So we're finding that the global movement analysis is a really unique opportunity to do just that, is to evaluate the entire body as multiple systems. And here's why too. And I've used other examples in the past, if you've heard me present, is that the majority of adults have comorbidities. In other words, they have something else that's going on, and especially people that actually have foot pain, they have multiple things going on. And so to be able to pick up on those things, even if it's not something that we may treat conservatively, but to refer them to the appropriate person, earlier intervention costs less money and it improves outcomes much more dramatically, right? So I also use it as part of my basement assessment. We use it for benchmarking. If you're able to work with larger cohorts or get people to return on a regular basis, if you go into school systems, older adult communities, it's just something that we test regularly as sort of that baseline, because it's real simple and easy, and we're going to be able to see some of those developmental processes. And that, lastly, movement, dysfunction is not just about pain. That by the time someone's experiencing pain, I won't say it's too late, but it definitely changes the potential opportunity that we may have had, right? Even, seeing changes in foot pattern throughout the gait cycle and the walking cycle, the running cycle, or the jumping cycle, we could easily correct some of those things before it becomes much worse. And
Thank you, Chris.
lost my screen. There we go. All right. Hey, so I did it.
You sure did. Thank you so much.
So we've got a couple minutes. If anyone has any questions, know that these are recorded, so we'll be able to see them at a later time. You have our contact information if you want to reach out if you have questions at a later date. I want to be respectful of people's time getting back to work and getting to bed if you're on the other side of the world. So that could be an important thing. But I just want to thank everyone for taking the time to listen, and we look forward to seeing you again, and would love to chat more. So do we have? Thank you, Robin. I appreciate that. Chris, based on what you said about the difference between locomotion analysis and gait analysis, would you describe treadmill walking and running as gait analysis rather than locomotion? That's a really good question. And I was having this discussion, in fact, just a little bit earlier. So I do it two ways. If we can actually have them walk in a more neutral or natural environment, one of the reasons is self-directed speed and mobility patterns can give us some information. So speed in general, as I mentioned earlier, as a predictor of morbidity and mortality, is a good thing. I use a treadmill too, and I still refer to that as locomotion analysis as well. Basically for those reasons, because of the description that people use and may shy away from if you say gait analysis. I will say, depending on where you are, so I don't think you're US based, Ramsey, but in the US, like our billing codes, for example, have specific, criteria, and it does qualify. So whether it's over ground or on a treadmill, you can use either term, and it would be absolutely fine. And the reason is because the forces, whether you're on a treadmill or not, they're not exactly the same. A lot of treadmills are actually designed to have a cushioning effect to them, so the loading is going to be a little bit different, which is why it's kind of unique. So one of my systems, I do use a treadmill, or both systems I can use a treadmill. The other one I can actually use, it's untethered, so I can literally have someone go run a 5 kilometer event and look at that data actually during that particular event. So now we're not getting any of those cushioning effects or reduction in load as a result of the system that they're on. Britt, if you see anything in the screening, would you always change it? And what if the change causes pain that they did not have before? That's actually a really good question. So what's interesting is there's several pieces of literature out there, and when they evaluated locomotion, specifically walking, in patients that had painful conditions, let's say low back pain, for example, what they did was they didn't treat the back. They specifically just oriented and used inserts, or they corrected, in most studies, just corrected the spatial temporal parameters of the walking or the gait analysis, in showing that it had a positive impact in whatever the condition was. Now, I think what happens when we are introducing something, we need to be careful. So I never go full all dramatic. In other words, if you've identified a leg length discrepancy of, let's say, 4 centimeters, you may go in and you can try all 4 centimeters all at once. If they've had this for a long, long time, you may need to work up to that, right? Because that's going to be a very dramatic shift. And what happens is people, and really cool studies done in people with cerebral palsy and Paralympians, and we evaluated this in Paralympians as well, is they've done such an amazing job at overcoming their limitation, is they've corrected a lot of that. They still have, the asymmetry in certain parameters, but they've shortened their standard deviations, their variability in those parameters, so tight that there's almost zero, right? So if we were to go in and correct some of those things, it may actually result in a bad thing in people that were very, very chronic. But if you were actually working with someone who just had a total knee arthroplasty, a knee replacement or hip replacement, and you've been able to pick up on those deficits, those you can probably correct much sooner. So if they're smaller and more acute, you're more likely to be able to make those corrections. If it results in increased pain or abnormalities, then you either need to go back and figure out what to do differently, or you need to take it a little bit slower in terms of what it is that you'd like to make as far as some of those changes go. All right. I think we're over our time, so we will stop there. But again, thank you for the great questions. Thank you for listening, and be on the lookout. So we've got more coming in the near future. I think we're good.
All right. Thank you, everybody. Thanks for attending. You'll get an email with a follow-up and a link to the recording. Have a great day.
Awesome.
Thank you, Chris.
Thank you, Josie. Bye-bye.
Bye-bye.